resistance training throughout the age spectrum is probably one of the best things you can do for overall health, and maybe even more so in older age when the body naturally begins to wind down and time is maybe working against us biologically. Resistance training is one of the best ways to stave off and be resilient to the effects of that.
Hi, Luke. It's my pleasure to have you on Evidence Strong Show for the second time. For two people who haven't seen the first interview, could you briefly introduce yourself?
Absolutely. And thank you, Alex, again for having me on for the second time. So my name is Dr. Luke Pelton. I am an assistant professor of exercise science at Springfield College in Springfield, Massachusetts.
All right. And your interest is in hormones and athletic performance. My audience is more on the strength side. And today's topic is menopause. So my goal for 2026 is to bring a little bit more science and clarity to the topic. And you are the first guest. So I'm super excited to have you. Thank you for saying yes to this interview. And let's start maybe with a definition, so we have a clear start point for the conversation.
Absolutely. And actually, before I do that, to kind of fill some of your listeners in as well, who may have caught my last episode where I talked about anabolic steroids in strength athletes, they may be wondering what's the connection between anabolic steroids and menopause. As you correctly mentioned, Alex, my main area of kind of research focus is in hormones, specifically reproductive hormones like testosterone, like estrogen. And, in doing research over the years, I found quite a bit of overlap between some of the kind of methodological and theoretical underpinnings in anabolic steroid research that also trickle into menopause by way of things like menopausal hormone therapy, which we're going to talk about quite a bit today. So that's kind of the background and connection here. Obviously, myself, not a menstruating person, will not be going through menopause, but there are quite a few glaring gaps in the menopause resistance training research that I think your listeners may be interested to hear about. So menopause itself, what is it? It is the permanent cessation, stopping of the menstrual cycle resulting from a very, very large drop in systemic estrogen levels. Specifically, it is defined by 12 months following a woman's last period that she has, which would mark the end of what we call the perimenopausal years. So we have premenopausal. Perimenopausal is when estrogen begins to drop due to some reasons we'll talk about in a little bit. And we have some of the symptoms start to kind of pop up, and then that can last for a number of years. And then obviously after 12 months of not having a period, we would call that the onset of true menopause. You're in the postmenopausal period. There can be surgically induced or chemically induced menopause if you have an oophorectomy or a hysterectomy that would prematurely induce menopause. Potentially, certain types of chemotherapy can also either transiently or potentially permanently induce menopause due to their effects on cell reproduction across the body in general. But that is the basic working definition of menopause that we have. And for most women on average, for white American women, I will say the age tends to be on average about 52, anywhere from 45 to 55. We do tend to see in Latin American and Black populations that can be about 2 years earlier due to a number of socioeconomic healthcare disparity reasons as well. But that is the general age we tend to find it occur in. And because of that, we also see that on average, women tend to live longer than men, which means they spend on average about 40% of their life in menopause, which can add up to about 30 years of their life. So if we think about some of these negative changes that can come about, it really drives a lot of the research to how do we improve the health and life and therefore enjoyment of life for people going through menopause.
Do we know why menopause happens in women?
Yes. So mainly due to the fact that from the minute we are born, there is a clock that starts ticking. And with women specifically, or anybody who is going to at some point ovulate or have ovarian follicles, that's where we see a lot of these things start. So in utero, a female embryo has about 6 to 7 million germ cells that would become eggs, oocytes in the ovary. At birth, that number is down to about 1 to 2 million. And by the onset of puberty, that's down to about 400,000 potential eggs that are left. And at menopause, that's down to a small handful. Part of this is due to atresia, which is when the eggs are kind of resorbed back into the body and then they're gone. Even during a normal menstrual cycle, you could have a very large cohort of about 10 to 30 that are recruited, but only one of them is going to ovulate. Only one of them drops, becomes a true follicle going into the uterus. The rest are atretic. They're reabsorbed back into the body that way. So, you're losing a few dozen every single cycle over how many ever cycles, probably about 12 per year on average, we would say. And then over that many years, we can see how quickly these could go down to quite a few by the time a woman gets to menopause. We also want to look at the deterioration of those oocytes, those potential follicles. With age, we'll see things like abnormal chromosomal division, decreased mitochondrial quality, so therefore energy production will be altered, DNA mutations, oxidative stress, and decreased antioxidant levels with age. So all of these things, these factors kind of come together and they'll build with age and result in a low number of ovarian follicles, and the quality of those follicles might be lessened as well. So where that plays into the onset of menopause, the ovaries themselves produce estrogen. And estrogen, as a steroid sex hormone, operates on a negative feedback loop with the pituitary gland and the hypothalamus therein. So when your body has estrogen levels, it sends a cyclic feedback loop back to the brain, which then alters the production downstream. And we see that reflected in the menstrual cycle. So we have a rise in estrogen leading up to right before ovulation, and then we'll drop again and rise a little bit through the luteal phase of the cycle, and progesterone kind of follows an opposite-ish kind of pathway as well. So we have these, cyclical waves, which is where we get the menstrual cycle from, this pattern of, follicular development, ovulation, and then either implantation with pregnancy or corpus luteum development, and then the shedding of the lining, and in menstruation, the whole process starts over again. So the ovaries are producing estrogen this entire time, and what we see with deterioration of overall ovarian kind of status, as we talked about, this decreases. So this leads to a production of increased follicle stimulating hormone. So follicle stimulating hormone is a precursor to many of the processes that we see in both males and females of gamete production. So going into the perimenopausal years, the body has this surge in follicle stimulating hormone, which is kind of what many texts will call like a last ditch attempt to stimulate follicular development. The body, if we think of biological reproductive drive, it is to reproduce. So the body's saying we're going to throw what we can to try to get one more or a few more to drop so that maybe conception can occur, etc. This could start as early as 35, and this depends greatly on the individual, obviously. But when that happens, we see estrogen is very, very low. Progesterone is even lower than that. And we're talking lower than we would see at the lowest levels throughout the menstrual cycle.
Right.
We also see a shift in the type of estrogen. So there's 3 types of estrogen. There's E1, E2, and E3. E2 is what is called estradiol, and that is the typical estrogen we think of. E3 estriol, that is actually what predominates during pregnancy and gestation. But then E1 estrone, that is the predominant estrogen that is produced during the postmenopausal years, mainly from adipose tissue. And E1 estrone is often linked to the development of hormonal breast cancers and uterine fibroids as well. So it is a different form of estrogen that we tend to see. Some of the symptoms that we see with the onset of the perimenopausal period, menstrual cycles start to become irregular. They might be shortened, or might have progressively longer periods of time between, which would contribute to what we call like oligomenorrhea, which is when we have a kind of scattered, non-consistent pattern of menstrual cycle, and the corpus luteum doesn't form. So, if the follicle is not fertilized as an implant, it becomes a corpus luteum. Those don't really form as much. We have decreased luteal function because of that. Therefore, progesterone decreases. Estrogen is now unopposed, and this contributes to some of that profuse irregular bleeding that we'd expect to see kind of through those perimenopausal years. And as we talked about before, gradual decline in the total number of follicles, those oocytes that are there. So, with we mentioned inflammation and like oxidative damage, we tend to see a increase in the kind of pro-inflammatory milieu of cytokines that are released, again, many of these from adipose tissue. So if in age we're becoming sedentary, less active, developing more adipose tissue in the kind of central visceral region, we might see things like interleukin 1B, 1A, 17, tumor necrosis factor alpha, contributing to an increased pro-inflammatory environment. Interleukin 1B specifically is often seen in cases of infertility or early pregnancy loss or preeclampsia. So a lot of these conditions are set for poor reproductive function, or signs of reproductive function starting to decline over time. We start to see the uterus as well undergo some changes. So we have cellular senescence senescence, which is like programmed cell death, more inflammatory cells in the endometrium in the uterus, obviously reduced pregnancy rate, increased chance of loss, miscarriage, etc. So a lot of this comes along with what we call like a geriatric pregnancy, which can be as early as like the 35 to 40 years. Individual status plays a role in this. Obviously, exercise and training and the kind of biological age versus chronological age can play a role here as well. But that's kind of the setting the scene hormonally of what is happening over the years that contributes to the environment, which eventually leads to the perimenopausal and postmenopausal years.
All right, so it sounds like a lot of negative outcomes happening in this window from 35 to 52 or 55. Let's keep it around 55. So it's a 20 years of issues you just laid out for us. Are there any good things about it?
Sure. And I do want to clarify, most of the heavier symptomology is going to be more in the approaching 50-52 time period, like 45-ish. The specifically from about 35 to 40, that would be risk of geriatric pregnancy with some of the things we start to see. So I don't want to paint a too dire a picture of what's happening or scare anybody, obviously. And these are on population level averages, right? Everyone's individual results may vary drastically. And much of it is negative. A lot of the symptoms that come along with peri and postmenopause, hot flashes, vasomotor changes in mood and outlook, uretogenital changes, they are not favorable or desirable, we will say. Good things that occur, I mean, the rest of life that's hopefully still going on obviously can be great. And I want to say what we try to do during exercise intervention where I come in, or then obviously any medical intervention or lifestyle intervention, is maintain health status and mitigate the side effects of these symptoms so that, again, life can be enjoyed, training can be enjoyed. But again, this is going to differ obviously person to person.
All right. So you flagged a little bit that the lifestyle and ethnicity, some maybe genetic factors may influence how heavy the symptoms are, when they onset, and how long they go for, and so on. So that will be individual. Now, if we think about strength athletes or power athletes, how the additional stress of training will play into all these natural changes in hormonal levels and other symptoms, how they will play into it.
Sure. So I would say being a strength athlete or strength training individual is probably one of the best things you can do throughout your life to, again, prepare for this time or to mitigate the symptoms or the seriousness of those symptoms. You know, what we tend to see from the research time and again in what is still a relatively under-researched area, I do want to say that, but the consensus tends to be that resistance training is fantastic for peri, and postmenopausal females, and obviously anybody in particular, but especially if we think about a population that might be more at risk for the side effects of not doing resistance training. This comes from a few directions. One of the most common side effects or end results of menopause for many, and this is not where my research expertise is bone mineral density.
Mm-hmm.
So very often postmenopausal women can become osteopenic or osteoporotic, which is a lack of bone mineral density down to about 2.5 standard deviations below the mean. Has to be diagnosed via DEXA scan to confirm. But it's a huge risk factor. So bone frailty can lead to injury and then the disability, and that is part of what we call the cycle of frailty. So in especially geriatric populations, postmenopausal women, if they're going to develop osteoporosis, again, they get injured, therefore they're sedentary, they decondition, they're more likely to get injured, and the cycle continues on and on. So resistance training is fantastic because we have direct bone loading. Power training is great because that often involves impacts, and impacts are what is necessary for bone remodeling to occur. So the maintenance of bone mass, impacts are fantastic. So if we're doing something like box jumps or even a cleaner snatch, there is an impact and from the feet and the lower chain as part of that. And also, top-down loading, that is about as musculoskeletal loading as you can possibly get. So those are really, really fantastic exercise choices for somebody in the perimenopausal or postmenopausal years, and especially beforehand. Training that way throughout life can definitely mitigate this loss to a certain degree. And I'm not saying for certain that you can train fighting your way out of these side effects, but it does, all of the things being equal, seem to give you a better chance of resilience of some of these maladaptations. The other obvious choice is going to be lean mass decreases that we also tend to see through kind of the perimenopausal years. What we've found is that in the postmenopausal years, absolute, like overall lean mass will decrease slightly, but relative lean mass decreases substantially because fat mass tends to increase. So even though your overall lean mass might drop a little bit relative to overall body mass, because if you're gaining fat mass due to being sedentary or hormonal changes, that relative lean mass might drop. And that is what can become challenging because lean mass helps prevent against insulin resistance. Muscle is insulin sensitive, and also strength and function, as we talk about. Muscle mass is needed for that.
What, in terms of muscle building and adaptation to training, what hormones are doing, which hormones are doing what, and then in the light of menopause, how that may affect muscle building, muscle adaptation, developing strength, power, or maintaining these.
Sure. So when we look at hormone therapy as a broad topic, it's generally going to be things like estrogen, progesterone, and testosterone. In males, it's HRT is usually called TRT in the concept of like aging, right? So it's testosterone replacement therapy. But again, is it replacement or is it just supplementation? Different episode. We often see HRT used in certain gender affirming therapies as well. In the postmenopausal years, formerly HRT, now MHT, tends to be estrogen, progesterone, single or combination medications that are provided, right? So those are the ones that we're trying to boost. There have been some which have also included testosterone in certain amounts. There's not a lot of evidence on those. We're really not going to consider them much today, unfortunately. But what we tend to see is that when we're replacing or supplementing, restoring, maybe hormone restoration therapy might be a better term for it, right? Restoring to previous levels, before peri and postmenopause. The idea is that by increasing those levels is that we counter some of the negative side effects that come with when they dropped in the first place. So looking at estrogen, progesterone, mainly estrogen, they are important for the maintenance of muscle health in a variety of pathways. Estrogen interacts with mTOR protein, which is kind of the master anabolic regulator in muscle growth and development. A lot of this research, not unfortunately, but for better or for worse, is from rodent models. So very difficult to kind of pull universal norms from rodent models to human research. We've seen that estrogen deficiency in these rodent models. We see reductions in mTOR and some of these surrounding signaling protein cascades that lead to anabolism. These are not universal. Some studies have shown that, some have not. Some have seen increased muscle protein breakdown after ovarectomy. So again, artificially removing estrogen levels. When they administered estrogen, it kind of reduced muscle protein breakdown to control levels. So we see that estrogen can potentially play a role in the balance of muscle protein turnover, the synthesis and breakdown, and that's happening all the time. But if breakdown is happening beyond the rate of synthesis, then we lose the muscle mass that we've been building and maintaining. We don't have as much human research that's linked activation of certain hormone receptors to these specific signaling cascades. Again, this is mainly coming from rodent research. What we do see in older individuals is that mTOR might be hyperphosphorylated, so might actually be blunted, and therefore this concept of anabolic resistance, where an aging population has difficulty building and maintaining muscle mass, that might be a potential reason why mTOR by itself is simply kind of not active the way it should be, independent of any hormones. Testosterone interacts with mTOR in a certain way as well, so decrease in testosterone levels might be a role here as well. So we have multiple different pathways by which muscle health is kind of maintained via signaling proteins or turnover, and the hormones that are there or not do seem to play a role in that, whether they are directly affecting or not. Still need some elucidation in human studies. Now, you talked about also, or asked about, how does this matter for things like strength and power training and the potential of training through that? So we mentioned that we do see some changes in lean mass and fat mass through the perimenopausal years. With resistance training be the most efficient way to combat that age-related muscle loss, strength, power, hypertrophy training would fall into that, right? So I would say if somebody isn't already training for strength or for power, for hypertrophy, starting might be one of the best things we can do. We're not going to restore hormone levels to the premenopausal years necessarily, but simply by building and maintaining muscle, we do tend to see some of the side effects mitigated. Something interesting that I've been seeing a little bit more of in research is dealing with hormone production from muscles directly. So in postmenopausal women who are resistance training, systemic serum estrogen levels decrease, so like system-wide estrogen decreases, but there have been some instances of increased local muscle estrogen levels, so being produced in the muscle directly. Jury's still out on whether that is a kind of compensatory mechanism for maintaining muscle health in response to resistance training. We see estrogen also plays a role in satellite cell health and function. So satellite cells, which we also spoke about, I think on the anabolics episode last time, satellite cells are kind of like muscle stem cells. So they are what help with the proliferation, differentiation, and commitment of immature kind of myocytes to becoming true part of, like, myofibrils, part of the overall muscle. So if satellite cell function is being blunted by low estrogen, then that could play a role in the anabolic resistance and loss of muscle mass. So if the muscles are producing estrogen locally, that could be a potential fail-safe against that. So yeah, it's really interesting research going on there right now. So that could be something to look out for in our upcoming years.
Awesome. So let's try to bring it together in a sense. Let's imagine we having female Olympic weightlifter or powerlifter who has to transition from being 40 to being 55, and they are training at competitive level, be it recreational or elite. How they should navigate, what should they expect, how fast the menopause may onset, most likely, statistically, on average, and what options do they have if the symptoms develop, and how they should manage their training. I realize it's a lot of questions, but let's imagine how it would flow and what the options are on the way to make things better.
So when we look at a sub-masters or masters level athlete, we're dealing with a very niche population, right? A relatively small sample size. So you mentioned that study on Olympic lifters. I've seen a few looking at masters athletes, powerlifters specifically, actually, both male and female, but those studies are few and far between, unfortunately. So assuming population level averages, the symptoms of perimenopause and menopause can be anywhere from 2 to 8 or beyond years. Again, averaging around 52. So likely we'll say around 45, those symptoms start to manifest. But again, with somebody who is regularly trained in a manner that is preserving musculoskeletal health, bone integrity, and is not overly taxing from a cardiometabolic perspective, because we can see perturbations in reproductive endocrinology from excessive endurance training. We don't really see that from heavy competition level strength or power training. It tends to kind of be a neutral or opposite effect in terms of that. So I would say that the timeline of the symptoms might be pushed back, but then again, that's on an average level. I'm not saying for certain at all. I really can't underline that point enough, is that we can do everything correctly, but individual results are going to vary. And you hit the nail on the head earlier when you said genetic factors. Every answer could be genetic factors, right? That's the easiest. It's individual genetics, obviously, but that's why we have research with population level norms and averages. The severity might be different person to person, so how those symptoms are perceived might be different. I mentioned those population differences, race or ethnic level populations. Lifestyle plays a role here. Obviously, if we have masters level competitive, like high level athletes training heavily, lifestyle is probably one of the more controlled factors that they have on their side. Nutrition is probably in line, sleep and stress management, social support, and training volume as well. That's one of the biggest things, obviously, you need to manage in terms of allostatic stress load that we're having. So that would probably mean that perhaps the severity of symptoms might not be as detrimental to somebody who has not been training or is not training. We might still see factors affecting recovery and fatigue during that time, though. We would most likely see this, or more prominently see this, in cardiovascular endurance exercise. So that impaired mitochondrial function I mentioned earlier, we see a decrease in VO2 max, so your kind of ability to take in oxygen into the cells, and kind of the gold standard of aerobic fitness. We would see fatigue set in a little bit earlier due to a lower stroke volume, how much blood the heart is pumping out per beat. There might be also a case to be made for, is menopausal hormone therapy something that we're considering? We talked about with the anabolics last time as well. High level competitive athletes are often looking for competitive edges, depending on where they compete, whether prescription is allowed or not. Again, the rules or statutes might differ organization to organization, but one of the largest things we do tend to see is that the effects of menopausal hormone therapy, if we're going to be deploying them, really depend on the time since the start of menopause. So all of the things being equal, we tend to see is that starting menopausal hormone therapy as shortly after the onset of menopause tends to be more efficacious than starting it later. What we also tend to see is that the age at which it is prescribed matters as well. I don't believe it is recommended to prescribe past the age of 62 or 65. I think it might be 65, forgive me, because at that point, the risk of the development of cancer of any type, but I mean, hormone sensitive cancers tends to go up kind of concomitantly with age there. There was the Women's Health Initiative study in the year 2000, which initially found the risk between hormone therapy and breast cancer, right? That was demonized it and doctors were not prescribing it. Within the last couple of years, it's kind of been found that that initial data set was not analyzed correctly or adjusted correctly. So we tend to find that an earlier prescription of MHT, earlier, like sooner since menopause rather, tends to be more efficacious and safer than if we were starting it later. It might not have the same effect and it might actually be detrimental past a certain age. But going through like the 40 to 55-ish time, like you said, like that might be the ideal time for somebody to use menopausal hormone therapy if that is what their doctor decides is a good course of action. It's not needed necessarily for everybody. It's not something that I think every postmenopausal person should be prescribed just as a matter of course. It is like I said, an individual case by case basis need. And I would, much like I argued with anabolic steroids last time or posited last time, resistance training, diligent attention to lifestyle and nutrition, all these other factors probably could do quite a bit to, again, preserve musculoskeletal health, exercise capacity to a certain point before needing, oh, I'm in menopause, therefore I must go on menopausal hormone therapy. And that is like the big topic of debate in the science communication sphere right now, especially with the American FDA recently taking the black box warning off of menopausal hormone therapy. So it's a rather tenuous time for kind of research and communication surrounding hormone therapy.
So is the game try not to lose what you have, kind of?
Yeah, you could say that definitely. Yeah, I would. Yeah, if the best time to start lifting was maybe 50 years ago, the second best time would be now. It's much easier to preserve than to build, especially in aging situation. In aging alone with anabolic resistance, with the hormonal milieu and symptomology of the peri-postmenopausal period, going into that already having been trained with a healthy, appreciable level of muscle mass is probably in people's best interest. Yeah.
I think any coach that has an athlete in their 60s can see the difference between how they behave, how they carry themselves, how sharp they are in the conversation versus general population, age-matched person on the street. It's obvious that something is special about this training population. So that is possibly an indication that it's not only muscle, it's not only strength, it's also function and some other benefits we haven't researched yet, but there must be some, because these people don't stop. They see, I don't think it's only, oh, I have more muscle. It must be some other benefits, mentally, functionally, socially even, that drive these people to continue lifting.
When you look at the kind of once an athlete, always an athlete mentality, right? It's in my doctoral years, in my fellowship, I reviewed a lot of master's theses and whatnot from across the school. And a lot of the kind of sports psychology students were looking at the transition of college athletes to the post-athlete life. And many people struggle with that. So when you have a sport like Olympic lifting or powerlifting even, or endurance running, where we very easily have a way to continue competition throughout the lifespan, it's you get to do it. And yeah, I definitely see a lot of masters level athletes in those sports. I think for that reason, it's relatively easy to continue that sport on throughout life. And whether or not that is what's wholly or partly responsible for mental acuity and overall function, I definitely think there's something there based on what we've talked about, what we've seen in research.
Right. Should we talk a little bit about coaching and how coaches should approach menopause and how should they work with the athletes? What is important?
Yeah.
So what do you think coaches should do? What should be their approach when they are working with perimenopausal and postmenopausal athletes?
So I think we would still consider this what we call like a special population in the literature or in exercise science, where there are some potential consideration specific to that person that would not be just normal training. I would say by and large, most normal training practices could simply be carried on with a postmenopausal population, other than what we spoke about earlier with maybe some blunting of anabolic responses or slight losses in lean mass, maybe increases in adiposity. For the most part, many adaptations are going to be roughly the same. That is what we tend to find across the research. I would say one of the biggest mistakes I could see a coach making is not progressing or loading enough, like holding back on the athlete. Some coaches trying to prescribe hormone therapy off label or without a medical professional or using other peptides, etc. Especially, like you said, when the money's involved, like, oh, you need to take this like special thing that really, I think needs to be frowned upon and brought to light as a real issue right now. And also encouraging person-centric coaching. So you are coaching this individual. You are not coaching somebody with menopause. You are coaching, Mary or Alex or it's anybody who happens to be somebody who has menopause. So person first and person first language, person first focus in terms of training what their goals and desires and what they're looking for in terms of outcomes and whatnot. And also, with maybe a new client coming to you with very large desired outcomes from training, right? Maybe they've never trained before or haven't trained a long time and want to lose 20 pounds of fat mass and gain muscle because they saw somebody online maybe doing like, cleaning 100 kilos or something like that. And being able to be honest and transparent, but also, optimistic and show like, hey, here's research suggesting that like we can do great things, from where you are now. And we still can make improvements there. A lot of what we see recommended in the social media sphere is women of any age, and especially those in postmenopause, should avoid zone 2 cardio, should only do strength and power training, or that should be most of their training. And I think that there is a place for balance, of course, and we need all of those things, but it's about, like I said, it's about balance. It's about not just doing heavy strength and power training, but more volume-based training within recovery means and whatnot. So, coaches need to not fall prey to the sheer volume of information that's out there that may or may not be true. Be skeptical about the information they're getting and having a judicious eye, scientific literacy, and being able to stay on top of the recent research in training practices so that if they happen to get a client who is postmenopausal saying, based on population level averages, here's what we expect to be the relative outcome for somebody, in your position. So we're going to approach that and then we will modify training as we go, which is what you would do with any client, any training style of any age. So it's really about being sensitive to the needs of the person, where they're starting from, where they want to go, and just really taking a person first approach to that coaching.
So what I'm hearing is that we should focus on what can be done versus bringing up all these barriers. You shouldn't do this, you should do and so on. So
yeah,
that's very optimistic.
Yeah. My from when I've coached, or I do continue to coach, I have clients now. I'm always a fan of the what can we do approach, not here's what we can't do, right? So, with a client who wants to improve body composition by losing fat mass, it's not we can't eat this, we can't eat this, we can't eat this. It's we're going to move more, we're going to lift more, right? We're going to incorporate more whole foods or more vegetables. So it's like adding and doing more. And like you said, like the positive versus the negative, as opposed to we can't do any of this. Or it's like, oh, you're going to lose bone mass. It's like we're going to preserve, we're going to build. This is what we can add and can do to, go into that later chapter of life, feeling our best and with function and dignity and grace.
Well, definitely at the start of our conversation, that was the picture that I had in my mind. All doom and gloom, it will be bad. When we're finishing, I feel like there are things we can do. It is individual anyway. So being aware what can happen, when it can happen, and adjusting your training as the things emerge, as athletes do anyway. This is an essence of training in any sport, is to adjust to the external things. So you adjust, you adapt, you train for it. So that's definitely, the vibe is different now. So thank you for that.
Of course.
Okay, so what is still unknown? What you should, as a coach and as an athlete, keep in mind while considering menopause?
So if we look at the current state of the research in this area, we've alluded to some of these things already. Much of the research has relatively small sample sizes. There are discrepancies or variations in how the outcomes are assessed. With menopausal hormone therapy, its efficacy, dose, duration, timeline, all these different things, which we don't have a lot of research suggesting one cohesive narrative. And then also within resistance training, the paradigms of volume and intensity, exercise type, modality, etc. There's a lot of variation there. There's been a few systematic reviews recently in this area in which, rep ranges were anywhere from like 3 to about 30, with an average about that kind of 8 to 10, 8 to 12 range, which again, we'd expect from any resistance training study. But there's a lot of gray area without any kind of clear this or that, which I'm not saying there needs to be, because the beauty of science and in life is that we have this center point with variability surrounding it on either side. But it's just, we just need more research with more robust sample sizes and comprehensive and kind of agreed upon standardized measurements for how we're operationally defining the variables that we're both using and then measuring in these studies. Anybody doing research in this area, I really encourage them to talk with other researchers in the area, which I think we kind of mentioned on the last episode as well, is that multi-site collaboration allows for a larger amalgamated sample size, and we have standardized methodology throughout one entire project that could definitely make some breakthroughs in this area soon, I think.
Awesome. So hopefully that will happen. There is a few groups doing research in this area, so please talk to each other, guys.
And I'd love to hear from some of them. I'd love to be involved if they want to get me on board.
Yes. Awesome. So what would be your take-home message for coaches and athletes around menopause? Let's bring it all together and have some kind of strong point for people to take from this interview.
Sure. I would reiterate things I've said before. I would say treat the person as a client first and foremost, as an athlete first and foremost. Pay attention to where you're getting your information from, work on scientific literacy, and try to avoid hard and fast, definitive takes on what you're reading.
Excellent. 2 questions to finish. The first one is, what would you like coaches to stop doing today?
What I like coaches to stop doing today, I would like them to stop arguing with each other about who has the best approach to training. I'm sure we've all seen this a lot on social media, coaches, practitioners bickering about it's this, no, it's this. When we see two methods that both seem to be efficacious, the interesting question is, what's the commonality there? Like, how are they both working, right? Again, variety is the spice of life, so they say. So I would like coaches to, as Ted Lasso says, be curious, not judgmental, right? So if we have somebody who's a practitioner in menopause, either exercise or wellness, and they have a method that seems to work for their clientele or for themselves, and then someone else has something different, or science offers something different, I think it's an interesting thought experiment or real life experiment to try to find, like, where is the overlap? How can we reconcile these two seemingly different things? So I'd like coaches to stop doing that and take more of a curious, collaborative approach to solving some of these issues.
Awesome. And the last question is where people can find you online if they want to ask a question or see what you are up to in your research.
Sure. I'm pretty much only on Instagram, so they can find me at Dr_Lukey_lifts. And I'm sure, Alex, you'll put that in the show notes for everybody. You can email me as well. My email is pelton@springfield.edu. That's my academic email. And especially anybody with a research-related question, I'd love to discuss more there.
Awesome, Luke. Thank you so much for today. It was a pleasure.
Absolutely. Thank you for having me.